We're going to get started now. Hope you've all had your coffee and your sweet snacks. My name is Alyssa Mialene. I am a journalist at Delicate. My name is Alyssa Mialene. I'm a journalist at DevX, and I am thrilled to be guiding us through today's conversation. I'm lucky to be here with a phenomenal panel, who I will introduce you to in just a moment. But before I do that, I want to set the stage a little bit for what we're talking about here today and what we hope to get out of this conversation. So we're here today to talk about cardiovascular care, right? And how key advancements in cardiovascular care can provide learnings or examples across the global health space. Now, we're going to get into that in a couple of different ways, with innovation in AI, with equity challenges and access, with how to create a public-private partnership that works in the health space. But let's just set the scene a little bit in terms of the issue of cardiovascular care first and foremost. So we're 5 years away from 2030, right? The Sustainable Development Goals target. Yet SDG 3.4, which aims to reduce non-communicable disease deaths by 1/3, are far from where they should be. One issue is that cardiovascular disease remains the leading cause of death across the world. In fact, it's responsible for 32% of all deaths, 1 in every 3. And stroke ranks as the second leading cause of death, affecting 1 person every 3 seconds. Now, these figures are more than just statistics, right? I mean, again, 5 years away from 2030, they're a call to action and a call to do more and to learn from where we failed or where we're not succeeding as we hoped or should be. And I'm sure that's why many of you are here today, to learn how we can take this call to action upon ourselves, change things, create partnerships, create better innovative solutions, and really get to the core of these issues. One way we can do that is by looking at the successes, right? And today's session will talk about how breakthroughs in cardiovascular care, despite all the challenges that still remain, from prevention to access to innovative technologies, can bridge some of these gaps. So, thank God it's not just me who's going to be describing that to you. I have 4 panelists here that I'd like to introduce you to. So directly to my left, we have Dr. Carla Goulart Peron. She's the Chief Medical Officer at Philips, and she leads efforts to prioritize safety and quality. We have Dr. Eric Cioè-Peña, the founder and vice president of Northwell's Health Center for Global Health, which brings health assistance across the world, which I'll get into. Then we have Sabine Bolonhini, the CEO of SAS Brazil, which focuses on health innovation, access, and specialized care throughout that country. And last but not least, we have our second Carla Haddad Mardini, and she's the director of private fundraising and partnerships at UNICEF and oversees private sector engagement on a number of different sectors. So let's dive in. Let's first start by talking about cardiovascular care. And Carla, I'd love for you to kind of dig in deeper to what I've just mentioned about the challenges that still face us in cardiovascular care, where we're at as a community in dealing with this challenge, and what type of challenges remain.
Yeah, so thank you very much, first of all, for this opportunity to be here with very special colleagues that I just met, 2 Carlas, 2 Brazilians, and 2 physicians, kind of like a lot of twos and a lot of good coincidences. So I think that's an amazing opportunity for us to truthfully discuss this matter, which is such an important one, right? We are in 2025, and still cardiovascular disease is a big burden worldwide. And it is, no matter where we are, which is a very interesting concept. If you are in high-income countries, in low-income countries, in mid-income countries, even in big cities, right, there is huge discrepancies depending where you are geographically in the planet. And unfortunately, there is a huge burden on everything for risk factors like hypertension, diabetes that can definitely impact cardiovascular diseases significantly. Those are very easy things in theory for us to control. There is challenges with them diagnostic, definitely challenges in getting access to the right type of diagnostic. There is challenges of having those patients referred to the right places, and challenges also in offering the specific types of treatment. If we think about specifically stroke, which I'm very passionate about, and I've been talking a lot about it in different platforms, right? This is a completely preventive disease, is a treatable disease. And even in stages of advanced kind of diagnostic, we still have technology and treatments available to cure this situation. And unfortunately, very few patients actually can get access to care to those diseases. And I love to say, I'm a Brazilian. I am also American, and now I'm in the Netherlands. So I've been able to be in those different parts of the planet, and I could experience myself that difference, right? So if you think about UK, depending on where you are in London, right, you can have access to a stroke care center where thrombolytics and thrombectomy can be implemented in a matter of minutes and save lives. But if you are sometimes a few miles from the city center, or actually a few miles from one of the big centers, you may not even have access to thrombolytics, unfortunately. And so this is something that we need to think about as a community, as individuals, as companies, as nonprofit organizations, as many of us here representing those institutions, needs to hold our hands and think about what can we do better, how we can use awareness first, how we can use all kinds of platforms to make sure patients understand how they can be at the center of those diseases and how they can impact their prognostics and their treatments. Also, how we can leverage technology, and we will be talking about, the role of companies like Philips that I'm here representing, definitely, that can bring telehealth, that can work with partnerships to enable AI and other types of technology to help diagnostic treatment, to help address the fact that we have a very real thing, which is shortage on staff, not well prepared technicians, physicians to actually deal with all kinds of diseases. And NCDs are a huge one, right? And so there is definitely a tremendous opportunity for us to make an impact in cardiovascular diseases, in stroke, for all the population worldwide.
Thanks, Carla. I think you've raised something really important, which is cardiovascular disease affects people everywhere. Whether you're in London or in the suburbs of London or you are in Guyana. So I would like to talk a little bit too, and I think I'll go to Eric with this question, about this particular statement that really stuck out to me when I was preparing for this panel, which is that 3/4 of deaths from cardiovascular disease, despite the fact that we know cardiovascular disease happens everywhere, 3/4 occur in low and middle income countries. Eric, talk to me a little bit about that, what you've seen in terms of access issues.
Yeah, I mean, to me, it's number one, thank you for having me on the panel. It's a pleasure to be here, and I share your sentiments about great colleagues on this panel. To me, I work a lot in low and middle income countries in my role in global health. I also am a practicing emergency physician in New York City, which I think is a high income country for now. We also, there's a lot of kind of complexity with addressing NCDs, as Dr. Peron just said. There's prevention, there's treatment, and as the low and middle income countries kind of transitioned from this kind of burden of disease, of communicable diseases, into NCDs, what we found is that it stressed parts of their healthcare system that they weren't prepared for yet. And so not that we're doing a great job in high-income countries yet with prevention and management of acute care and emergency care. I think we've still got a ways to go. But my partners in Guyana, they don't have the referral pathways. They don't have the non-invasive interventions. They don't have the screening tools. I mean, right now with the Minister of Health, we're talking about just universal diabetes screening, universal hypertension screening, and that's really low-hanging fruit. It's cheap too. And I think one of the things that I've been trying to convince our partners, and I'm successfully, that no matter where you are in the treatment spectrum, it's always cheaper for the country to start earlier. So screening and preventing, cheapest, right? But even with stroke, treating thrombectomy, even though it's expensive, the technology can be expensive to implement, having to deal with, we're talking about deaths, but disability due to stroke. Having someone in their 30s or 40s or 50s disabled by stroke for the rest of their lives is an enormous burden on a country's health system. And so we have to go upstream. We can start with the really low-hanging fruit of public health prevention, screening, referral, but I think all the way through to emergency care, treatment, is really, I think, going to be the financially most sound thing for every country to do. It's just for some of these countries, it's with their health budgets, it's a really steep slope. And this is why I think it's really important in public-private partnerships for not only for the private sector to be talking to the public sector, but for the different ministers of different public sectors to talk. Like the Minister of Finance, I think, needs to understand the economic impact of cardiovascular disease and NCDs in general on their population. This is a disease that often will affect the working class folks. And so especially in Guyana, we see very early onset a cardiovascular disease because of some epigenetic issues in the Indo-Guyanese community. So we're seeing 30-year-olds, 40-year-olds with disabling or fatal heart attacks, disabling or fatal strokes. And that's an economic, huge economic handicap for a country that's just coming into its coming from a middle income country into a low high income country. It's an enormous burden for that country to do if it doesn't address it.
Yeah, I mean, just think about that. 30-something years old and having a stroke. I mean, it's, it makes you pause and reflect a bit on what we're doing wrong, how we can fix these issues. I mean, before I move on to getting us to a more optimistic part of the conversation, I do just want to open the floor to Sabine. Curious, in Brazil and in your work with SAS Brazil, what else are you seeing in terms of challenges to cardiovascular care and the environment and climate of Brazil?
Yeah, so first of all, such a pleasure to be here. Thank you for the opportunity. As a Brazilian, I'm a little cold, but feeling the warmth of the room. So thank you for the energy, such an important discussion. We've been on the road for the last 12 years, delivering specialized healthcare to vulnerable communities in Brazil. Brazil, as Carla mentioned, is a highly complex country and diverse country as well. So 12 years ago, it was the first time that I stepped in a small city in Brazil that has less than 10,000 inhabitants. Brazil has 5,500 cities. And at that day, my life changed. I say that you can never unsee what you saw. And I saw a level of low equity and challenges of access that I had never seen before. And we live in bubbles, right? And I think this is a great panel to try to get out of those bubbles. In Brazil, we have so many challenges around resources and infrastructure and staff training. But I think a main challenge around health is how are we distributing health, right? So a patient in Brazil, you were talking about miles, we use kilometers. In Brazil, you have to travel 155 kilometers to get to a health specialist. So imagine that. You start feeling something on your chest, you have to travel 155 kilometers. That's not going to work, right? We have 86% of doctors in 6% of cities. So I think we have enough resources. I think the challenge is how do we distribute them? This is the key in terms of solutions. But sticking to the problem, what we see is it's a highly complex problem. When we talk about health equity and health access, we have to go beyond health. Right? We have to talk about education, we have to talk about finance, we have to talk about infrastructure. And I think this is the challenge. When we address health, we're addressing other challenges as well. So just to mention a quick insight that we had, since 2021, Philips Foundation has been a partner of us, and we started using a KPI that was since distance is a challenge, how many kilometers are we avoiding of travels by using technology? So we got to a number in our operation of 10 million kilometers avoided by patient travels. So that's huge, right? And we started developing tools thinking about that. I'll get more into details, but just to give you an example that why I think going beyond health is important. We developed a tool that created carbon credits based on the kilometers avoided of patient travels. And this could also be a tool to bring new resources to the table, right? If you're thinking about climate and health, If we start using that as a measure of impact, we could find solutions that are beyond the scope of a new treatment and so on. Because I think this is the kind of collaboration that we need in order to address those challenges. Because the way we are doing and the solutions we have, they're just not working, right? We're not addressing, as you said, Elisa. So I think this is the landscape in general, and I think the challenges we face in Brazil are across the globe. And I think this is also something that we want to strive for, is finding solutions that work locally but could scale globally as well.
I think that's a fantastic segue into what is working, right? What solutions do we have? I'd love to ask each of you about just that, right? What have you seen in your own lines of work that give you hope? You can talk about artificial intelligence, you can talk about technology, you can talk about more traditional approaches, but what's the first thing that comes to mind when you think about, okay, despite all the challenges that we have dealing with cardiovascular disease, what are the bright spots in this response?
Yeah, maybe I'll get started. I think there are a lot of bright spots, right? And we need to stay on the positive side and keep pushing to share those positive examples and prove to the world that we can actually do it. There is a way to make a huge impact. So I'll start by saying that we do have very good results by bringing together different types of technology and partnerships to improve access to care, right? And to actually push for more people having access to this and diagnostic and quick treatments and the right treatment, as we were discussing before. So I think Sabine mentioned, right, we do have a partnership through the Philips Foundation where we are enabling through telehealth and actually with echocardiogram online and ultrasound as point of care, using technology to actually deliver diagnostic, not with the need of having a super specialized staff in every single country or every single city we are there. So this is enabling physicians, nurses, sometimes technicians, right, to understand better what's happening with those patients, to triage them, and to send them to the right referrals. I think AI is developing itself, and it's going to continue to develop itself to help those physicians to be more precise in getting the diagnostic and actually to offering better treatment. So we were talking about understanding also the cost of implementing sometimes high-end type of technology or solution. So for me, it's a combination of AI to enable. It's a combination of partnership to create a possibility for us to develop different types of business models that enable companies like Philips, right, to end with the ability to impact more patients with the right way. And also, it is us coming together and sharing those examples, right? I love to say the fact that, 12 years ago, I was luckily enough to be part of the group that started the stroke network with them, Dr. Sheila Martins in Brazil, where they were looking for ways to enable mechanical thrombectomy to be implemented on the public sector there. That was unimaginable, right? Cost-wise impossible, infrastructure-wise impossible. How can we do that? And just by leveraging all those aspects of it, they were very successful to prove that even sometimes implementing technology that are more costly upfront, you can also impact patient outcomes, right? So that 30-something years old patient that may no longer be disabled permanently. But we also need to think beyond the patient itself. We need to think about the fact that a 35 years old disabled most likely will need someone, a family member, also to be taking care of that person. So the overall systems suffer. So for me, it's a combination of factors that it brings technology, partnership, industry, nonprofit, governments together, and teams like us bringing those success stories to life to show how much this can actually make a difference in outcomes at the end of the day.
Eric, let's go to you. What have you seen? What works?
No, so I mean, number one, I think it's important to be optimistic. My CEO describes himself as a healthcare optimist, and it's infectious. So I think I'm also a healthcare optimist. We're seeing technologies that for the previous 40 years we've admired problems, and we really do have technology at our fingertips that could really solve a lot of them. One of the big ones that you mentioned was this urban-rural divide with health experience. Telemedicine's solving for that a little bit. There's some connectivity issues still that needs to be worked out, but we're successfully delivering telemedicine care in the middle of the Amazon in rural Guyana. Using satellite and community health workers. And the thing that I think is really exciting is not just connecting the community health worker to experience, but also making that community health worker more potent of a healthcare actor through technology. So even in just, we see ultrasound technology becoming, you used to have with ultrasound technology to do an echo on someone's heart, you need to have skill. You need to know how to do the echo. We're getting to the point where you could really just kind of move the probe around the chest and the AI algorithm will get the pictures of the heart that a cardiologist remotely could look at. And we're seeing this in maternal care, cardiac care. So we're able to give more skill to people through these technologies and really upskill the entire health system. And when previous to that, we were really trying to figure out how to get the doctors from the cities to go out into those communities. And then the next generation of that was how do we train people in the community to be doctors because they're more likely to stay there. And we found that does work, and I think we should still do that. I'm not against training rural physicians. But, rural physicians often have to move for training. They go to the capitals, they find a spouse or a partner, and they like the lattes and the Wi-Fi, and they stay. And I'm a physician. I like my high-speed internet. So it's tough to get us out of cities once we're there. So it's twofold. So how do you bring the training to the rural communities? And so some of that eventually may be training physicians in those rural communities. But right now, we can certainly train and provide a lot of skill to community health workers. I will make a little non sequitur plug. Those community health workers should be paid. I just have to say that because I feel like every time we talk about community health workers, the majority of them are unsalaried, unpaid, and uncredentialed. And we have colleagues in our cohort of Schwab Foundation that are fighting for that. And I think it's an important point.
Great. Sabine, I know you've already given us an example, but perhaps for your next example, you can give us a wider look at what else is working when we look at global health more broadly, expand out of cardiovascular care to get us more looking at global health.
No, I definitely would resonate with what Eric and Carla said. I think what we are doing in health is transformative in terms of being able to bring this amazing innovation, technology, AI devices, so on, but actually bringing them to where people need it the most, like Eric was mentioning. Because I see health innovation as the key. This is where we're going to go and find new solutions to old problems. But I think the paradox with health innovation is it usually stays where people need it the least, right? So it usually stays in big hospitals, big cities, and so on. So you provide better care for people who already had a good care. And we have to be intentional, and Eric shared a great example on how do we make this amazing innovation get to the small and vulnerable cities, to vulnerable communities, be it in the Amazon jungle, be it in a fisherman village, be it in a desert across the world, right? And I think this intentionality around distribution also of innovation is the example that I really believe in. And in SS, what we do is we equip containers, we call them advanced telemedicine units, with devices like ultrasound, like ECG, and we train these local professionals to operate these devices, and usually nurses, but also technicians. So we upskill them, give them a better qualifying jobs as well, and make sure that they take care of the communities and themselves in a better way. So this is highly effective, and I think this is the model that we could scale. And the challenge is usually people who think about the innovation, they don't know how to get to the last mile. So there's usually two knowledges that are separate. And I think the big case, the success cases we have is when we blend them together, right? When we bring amazing innovation like the ones we use and Philips develops to the people that know how to get to the field, right? And I think this requires partnerships, this requires a collaboration. I like that this is the theme of Davos this year, right? Collaboration in the intelligence age. And also, I think this breaks a dangerous cycle that people that already have access to health with their data, they keep being the only ones that are feeding the AI models. I think this is also something that we have to bear in mind, right? How equitable, how diverse is the database that is feeding the models? If we only do AI training in big center hospitals, we have a huge challenge there. Already, this is something that we have to be careful. 85% of data in health comes from the global north. And as a Brazilian, this is concerning, right? So I think this is also a way to make sure that this technology is not biased and that the outcomes will actually provide better healthcare and better equity for everyone. I think this is also something that we must be intentional around, especially when we talk about AI.
Yeah, no, thanks for raising that, Sabine. I think there's something essential that we haven't brought up yet, right? Which is the financing. And how does this work? How do we get partnerships and how do we get partners together to really think about, one, how to do this work and how to come up with these innovations and bring them to scale, but also how to pay for them. For that, and for those of you who thought other Carla was going to get away with no questions, that's wrong. Carla, I want to turn the floor over to you. As we mentioned earlier, Carla is with UNICEF and leading this private sector engagement and partnerships. And I want to talk about appetite. You know, what is the private-public appetite for these types of partnerships? And for those in the room who are working on this, do you have advice for folks on how to really create a partnership that can bring some of these innovations and solutions to life?
It's actually great to be with you on this panel, and I really love the way you framed the issue, because when I got here, I was, my God, they are doctors. It's going to be very technical, and you know, they say that about us also when we do our jargony UNICEF speeches and interventions. But what I love about what you've done, and I'll segue to your question, is that you framed it in a way that we can connect to the story. And I'll connect it to the work of UNICEF and the challenges. One, you're asking about financing and funding. One of the things we've noticed is that prevention as such doesn't get funded. In everything, every time there's a crisis, let's go into armed conflict, violence, climate-induced emergencies, prevention is not funded, and the donors and the partners react when the crisis hits, when the stroke happens, when it's about curing. And there's something really fundamental in terms of the mind shift that we need to do in terms of looking at prevention as a good business model, and you've laid the case for it. So there is a big piece in UNICEF of finding new ways, non-traditional ways, of funding preventative measures because they make sense in the long term, and we need that mindset shift. So that's one thing. The second big piece that you've all touched upon that I connect also to our work and where we can collaborate as an ecosystem is equity. So we see it and we've experienced it in UNICEF around COVID and the pandemic and COVAX, the whole system around COVAX. So typically people would ask, why was UNICEF involved in COVAX? You were dealing in immunizations of children. The pandemic hit adults, the adult category primarily, and children were indirectly affected. How come UNICEF was involved? And actually what happened is because UNICEF has this last mile delivery experience in the field, in the remote areas, whether in Brazil, in Chad, in Colombia, on the other side of Asia, this cumulative experience made it possible for UNICEF to support the global ecosystem in doing that last mile delivery in low and middle income countries when it came to the supply and delivery of vaccines. So we became a member and architect within the COVAX entity based on experience, regardless of whether it touched children or not. But I'm bringing this because it's not a traditional way of doing work. And I think both prevention and equity should be the main driver for collaborations, and plus you're adding AI now for collaborations that are multi-stakeholder. And we have good examples. Let me give you one that I'm very proud of. So NCDs and mental health affect more than 2.1 billion children and adolescents under 20 years, and it's a silent pandemic. Because it's not visible, so you don't want to fund it, you don't want to prevent it, so you go into communicable diseases. Ebola, you'd have the whole world up in arms trying to find solutions. But on NCDs in low-income and middle-income countries, more problematic. And one of the great examples I want to share very quickly is on mental health. So we've aligned forces across Zurich Foundation and UNICEF, we started together building a mental health coalition for youth, and we thought, will anyone join this? I mean, this is like not very fundable, not very attractive to the sector. It took a couple of years, and now it's scaling. So you have Lululemon that joined, Sony joined, Pinterest is in the coalition. Many partners are joining the coalition now that we've proven it can work. And I think in terms of multi-stakeholder, public-private, multilateral engagements, you need that patience for the first, I think it's 18 months. And like I've looked at the part, it always takes some 18 months. The minute you have a few early adopters, you make the case, you start bringing different language, grammars from different sectors in a way that everyone can comprehend and feel part of it, it does scale. And then the minute it scales, funding trickles in. So there are, because I want to be optimistic about the potentiality of working together. And if you add AI now, there's really a great space that is still untapped where we could join forces, regardless of the disease and regardless of the issue. But it requires intentional collaboration, and it requires the belief that the financial returns will come eventually, and we need to really find the narrative to explain the social returns and for future generations. And this one is less palpable, but evocative storytelling like you've done here, I was watching you, impressive, really very strong, because the whole room was listening. I was watching. And then I was watching you look at me and think, this is not equitable. She didn't speak. I was watching you. No, but really, there's huge potential in that trend.
Yeah. And Carla, I want to dig into that a little bit further. This particular example that you gave about, this partnership, what do you think it took to get those initial partners to sign on? You mentioned kind of it was 18 months and it was kind of working. And once everyone got in, the flow came.
So it started, actually, I'll say it very quickly. Zurich supported UNICEF in a transactional way the first time around COVAX. They gave 2 million or 3 million. It was a first interaction. And then when they realized that we could do much more together, they said in their company, mental health is a deep-seated issue. For the lived experience in the company, employees, mental health is important. And they said, actually, we want to move away from a simple either CSR or just, tick the box we've supported on the pandemic into something much more core to them. So shared interest. And we started building it around that. And then because you have skin in the game, from the CEO to the employees, the foundation is very present in that. It became existential for them. So they wanted the partnership to work. We wanted the partnership to work. And now when I look at the deep bench of partners that have joined and counting, I think it's turning into a movement. And we've launched the On My Mind approach where youth has access and children have access regardless of where they sit in the world, whether they're in the global north or in the global south, because mental health doesn't have any borders and it's a plague that is really invisible. It's become something much bigger than what we thought. Beyond transactional, yes, we have a foundation from an insurance joining UNICEF and we can have the annual report. It's much bigger. Everyone is involved in this partnership. And when things get tough, you will have everyone lining up to find a solution. It's just a different approach and mindset to it. And I think this is what we need to get to when we're forming these multi-stakeholder initiatives. Great, thank you.
Yeah, I would be curious how that reflects on the rest of the panelists. Yeah, go ahead, Eric.
Can I just double tap on that? So I want to say that, so I'm in Davos. The only other Northwell member from our team that's in Davos is our SVP and Chair of Psychiatry, who's in the audience here, Dr. John Young. I think, so number one, I think I'm so glad you brought up mental health because it's the number one thing that every Minister of Health asks us in our partnerships for help with. And it's also, not to get too far away from cardiovascular care and other NCDs, but it is the NCD that's the most complicated because it also impacts outcomes of stroke and heart attack. And so there's so much complexity to it, but the payoff could be so huge if we got it right. And so I think there's a huge opportunity here. I'm really glad to see the momentum on mental health changing. In the States, we still have, the adolescent and youth mental health crisis is the worst it's ever been. The statistics on suicide and depression and anxiety are the worst they've been since we've kept the statistics. But I do think that we are at this kind of turning point. It's gotten so bad that I think everyone realizes we need to do more than just lip service for it. And so it's great to hear that UNICEF's taking a lead on that. We are also looking for ways it's literally, whether we're in Ukraine, Guyana, Ecuador, it's the number one thing on a Ministry of Health's mind when we say, what is a problem that you really don't see a solution for that we could help you with? It's number one on everyone's list. And so it's an enormous challenge.
So maybe I'll just build up on top of it, and not really related specific with mental health or cardiovascular disease, but about what can we do if we really collaborate, right? I think Carla mentioned something, right? When things get heated, then we come together and we find solutions. If there's one thing that the pandemic taught us is how much power do we have when we are all collaborating towards the same goal, right? And so cardiovascular disease, mental health, those things are already a burning platform. We're just not probably recognizing where we are and what is needed, right, for us to trickle the fact that it's time for us to do something about it, right? To your point, how we can get there. It's on top of mind of everybody. Mental health, cardiovascular disease, how we work around diabetes, hypertension, and mental health. I think it's probably those are the three top if you think about non-communicable diseases. So what can we do? Maybe it's a provocative question, differently, to convince ourselves that we already got to the level where there's no way back. Right? We need to come together and look for a solution. How we stay positive, how we share, good outcomes of partnerships, and how we bring the early adopters, just to Carla's point, right, up to the top to help them sharing their success stories to kind of trigger the collaboration even further.
I just want to add also, I think you mentioned a good point that it's about grammar as well, right? It's about the narrative. My mom is a linguistic, so I've always learned growing up the importance of language and communication. And I think a powerful message here is also private sector, public sector, NGOs, civil society. We have different languages sometimes. And I think it is important to know each other's narrative, right? You have to be able to dialogue and really listen to each other and learn from each other's languages, because they raise concerns, they raise interests, they raise what's actually matter for each one of us. And I think there's a space for us, if we actually listen to each other, to find ways to collaborate in a meaningful way, in a transformative way. And I think the challenge on NCDs is that they are silenced diseases, right? They don't raise this awareness of crisis like COVID did, the pandemic, or a stroke even, that's more urgent. And once the crisis is there, we act. And I think this is a huge challenge in terms of narrative. 2030, it used to be 10 years away, it's 5. 5 is still a long-term goal, I think. We are living every day, so we need to find a way to frame this narrative. It's an urgent crisis. Unless we actually do something now, we're not going to be able to thrive as a species, right? And solve the specific problems of NCD as well. And I think about collaboration, people engage with action. I don't think people engage with dialogue anymore. And this is one of the things that I like about bringing this tangible solutions. It's actually what we are doing. And it's so inspiring to see someone do something and move and, find the way forward. And I think you have great examples here. We discovered that our power also comes from being the ones on the field, doing the work, because you see the result. And we recently launched a collaboration between the academia, because I think this is also something important, right? Bring the data that show the impact that you are actually doing, performing, partnering together also with WHO now recently, Ministry of Health in Brazil, private sector, putting everyone on the table. We did a panel like this and everyone mentioned how important it is to have these conversations. And I think this is something that we really need to bring awareness and create other opportunities to do that as well.
So Sabine has started us off, and all the panelists have started us off with what can we do? But I do want to put the question back to Carla, because this is what you do every day, right? You know, making these partnerships. So what do you think are some advice that you might have for people hoping to cement this work and hoping to get more people on board, especially for these, as Carla mentioned, somehow forgotten and silenced issues?
I think where we struggle is maybe just to put it this way, we've used the COVAX terminology as a verb now in UNICEF. So you say, let's COVAX on this. Because we don't know what it is, but you've said it, Carla, we function differently. As a global population, the level of solidarity with all the issues that we've gone through was something unique. And actually, if you look at the private sector, there are two moments, and it's interesting to analyze that. There are two moments recently. It's the pandemic and then the war in Ukraine that have created tectonic shifts with the behavior of the private sector in ways that are unprecedented. At least in UNICEF, we had never seen that. It's the largest income into UNICEF's programs that happened in its history, record from the private sector. We had reached, and it's not about the money, but just to give an example, 3.1 billion. And it wasn't us going and trying to connect the dots. They were coming forward. A tectonic shift. How can we help in a meaningful way for the pandemic and for the corporate sector and for the war in Ukraine? How come we don't get that for the other wars? How come we don't get that for the silent pandemics? How come we don't get that on climate or on development reversals that we're seeing across the world since the pandemic? You know, when you look at the situation of girls, young girls and women in some countries, and we're 5 years until we reach the SDGs, if we reach them, it's scary, but there's something that doesn't happen. And I don't know, there's a recipe we need to find, but the minute you reach that kind of sweet spot of collaboration, and it does require involving your core assets, your core business. If you're talking Philips, it's the core business of Philips. It's not on the periphery. It's not the CSR bit. CSR is important, but we need to move away from a charitable approach to finding solutions into solidarity that brings the assets of every single entity in the value chain to the fore. It's a different mindset. I think we know what it is, but it's not codified. And maybe we need to codify this a little bit more and apply.
Definitely.
Definitely. I think in terms of language, it's the same, right? It's creating an awareness of where the impact is and what are the metrics and how do we engage and create this sense of what is working in terms of philanthropy or partnerships to bring this as a framework that can be scaled to other partnerships or other initiatives as well. I think there's a logic into it that we can actually tap into and try to scale it at a more effective way than we're doing now.
And it's okay to align motives. I mean, I think one of the things that USAID in particular is very scared of, I was actually on a focus group last year because USAID is frustrated that it can't engage the private sector. But I literally heard a program officer say, well, we can't fund something if a company is going to make a profit off of it. And it's like aligning profit motive and good things in the world is probably what needs to happen for us to solve all of these things. So I would say we need to make sure that motives are aligned so that we get the full force of the private sector behind this. I mean, the private sector gets a bad rap sometimes, and Northwell, we're like a nonprofit health system that acts like a for-profit. So we're very we're kind of straddle those two mentalities because healthcare really is a business in the United States, unfortunately. But you know, I do like the frustration and lack of patience in the private sector. And I think it's an important injection into the public health system to really move things forward. And we can do better at those communication and that language to make sure that, you know, people understand that, you know, it really is in the private sector's best interest to have a thriving, healthy workforce and economy in the countries that are affected by these pandemics or silent pandemics.
Can I react to that? I just want to say something on aligning the purpose and so where there is an issue, and it's a tough one for all of us, and us as UNICEF or any other multilateral agency or the private sector or a public sector entity, a government or multilateral, we need to pay attention to risks of blue washing, greenwashing, SDG washing, whitewashing, all the washing that, climate washing, climate hushing, whatever the terminology, because this is where we can put ourselves in harm's way if the collaboration is not meaningful and intentional. So if, let's take an example. Philips wants to have a partnership with UNICEF because the sole objective is to have that tool sold in that market X. That's an issue. Now, of course, there is this objective. These are for-profit company. But we need to make sure the intentionality is there. Maybe we will tell Philips, well, you can't do that there, but you can improve health systems across 5 countries that connect with cardiovascular, for example. There are so many ways to design a partnership with a portfolio approach where we have equity injected. Because the problem is when there's no equity, and then it's the market where my company is working, I just want to do that market. Then that doesn't work for us in UNICEF. It's not a meaningful partnership. And this is where we have amazing conversations, and I'm looking at my colleague, with our partners on what exactly is your interest. And there is the breadth and scope of what we can do together in a multi-sectoral way is massive. And then you design it on a portfolio approach. And that the private sector understands. And often they want to earmark to certain areas. We say, okay, can you inject in your portfolio a window of equity? And we had it for Ukraine. So many corporates were supporting our humanitarian response in Ukraine, which was critical. But then we got funded for our operation for those few months, and we were thinking about the knock-on effects of Ukraine on the Sahel region, on Yemen, on the Horn of Africa. So we talked to some of them and said, can you inject a little bit of flexibility in the funding for the others? And they said yes, because there's a nutrition crisis on the other end because of the grain crisis in Ukraine. So we are also improving the way we negotiate and propose. It's not just a charitable thing, fund us, fund our UN programs and our, cost of business. That's not the point.
May I share like 5 minutes, maybe a personal touch, right? So I'm Brazilian, finished my medical school there, residency, and my first job was in a suburb area out of São Paulo, right? Which is a huge city. We think about this as probably where you can get the best care in Brazil. So one of my first patients in that community practice that I was supporting was a 15-year-old kid, right, a female, that came my way and saying, I can't get pregnant. And in my mind was, and how this is a problem, right? You are 15 years old, we're not supposed to get pregnant right now. And she told me her story about that was the only way for her to get out of her house. And in her mind, that was a path for freedom for an abused family, right? So I finished my residency. I kept trying to do my best for those patients. And then some point I realized I can only touch 20, 25 patients a day. So what can I do differently? And that's how I learned about industry. And then when I decided to join, I heard from a lot of people and colleagues, are you going to join the dark side? And I said, no, I'm going to make that side a brighter side, right? Because I think this is personal. So if we cannot align goals of all the institutions and key stakeholders in this collaboration, we'll never be there. We'll never get there. So I decided to join Philips less than a year ago, right? And one of the reasons was because Philips has a specific goal of touching underserved communities, right? And this is it's true part of what the company wants to achieve, and it's meaningful. So we need to open up space and create a creative environment and a protected environment. How do we get there? How do we create a different business model, right, that can actually accomplish goals for all those different stakeholders? And this is personal. Companies are empty. We are the ones that make them live. So if we don't bring that to reality, we'll never get there. So maybe a little bit philosophical, but this dialogue kind of like push this memory for me. And I think it's very, very meaningful, right? So we need to align. There's nothing wrong if we're bringing UNICEF, Philips, SAS, Northwell, all those companies together and finding something in common that is this silence pandemic that we can all actually contribute with and make a difference and achieve the goals, which include making profit out of it for some of those institutions. There is nothing wrong or dark in that. That's how I personally feel about it.
I want to before we go to audience questions, which we will in a couple of minutes, I want to touch one last topic, which is scaling. And basically, how do we use partnerships and how do we use the innovation we've discussed today to bring programs to scale and touch more people, which is what Carla was just mentioning. I want to direct the question first to Carla and then to Sabine, and then we can continue with the rest of the panelists. But yeah, when talking about scale and making things bigger and better and not losing the quality of the program.
Scale is important, to your point. Otherwise, it's niche, and when it's niche, it gets a few communities interested, and that's it. I think where UNICEF can help is the fact that we're present in most, if not all, low and middle income countries with lived experience and decades of experience, whether it's a humanitarian emergency or a development setting. And so this is where we say we have boots on the ground and high heels at the humanitarian table or multilateral table. But
I love that.
I say the high heels because we end up with high heels, and the high heels is to talk about anchoring. The imagery is that. So we know what is happening in these areas. And where we can help is to share information on the country readiness when we think about health system strengthening, the issue of community health workers. You were mentioning the need to have community health workers paid. Most of the women, female community health workers, have done the work during the pandemic without being paid. We have huge equity issues on the entire value chain. And so I think if we were to collaborate more intentionally, you would leverage and monetize the information across every single linkage of the whole story. And there's the risk conversation too. Sometimes investments don't go to these areas because of a perceived risk, depending on how the country fares, if we're talking of Afghanistan or countries that are really complex right now in terms of development or humanitarian emergencies. And the question is the risk perception. This is where UNICEF can give an assessment on what is happening on the ground, because of a very strong presence across the country, across the communities. And this is where we can we can connect the dots better.
Thanks, Carla. Sabine.
Yeah, I just got to my memory as well how we started in SAS. Adriana is my co-founder, co-wife, a partner in life, in love. And she's the doctor and the visionary one. When we started 12 years ago, we were at 8 volunteers. We did 270 consultations during 5 days. Now we have over 2,000 volunteers, and we do 270 consultations every hour. When we started, she said, one day we'll have 500 telehealth units. And I said, no way, this is never going to happen. And I started believing in that. And I think what we've learned about scale is we don't want to do it alone. Right, because scaling health, every country, every region, they have specific regulations, they have specific norms and societies and cultures even. So what we've learned is the importance of partnerships, right? We've been on the ground and learning the work, doing the work, we made a lot of mistakes. And what the model that we have now, it's a model that is refined and it works, it has impact. So why not train other governments? Why not train other institutions to do what we do, to share what we've learned, but also tap into their knowledge that we'll never have? So I think scale through partnerships is the way to go. This is what we have been doing, especially this last year, to do an open source model, right? If I have a line of care around patients with diabetes or other chronic diseases or pregnancy women, we want this to scale, and we don't want to have to do the jobs ourselves. I mean, that's really tough, right? So we developed this open model source, this lab, and we are training other governments. I was just talking to the African CDC, and they're really interested in scaling that, and also through the universities as well. And I think this is the way to go and move forward. I think this is the importance of partnerships as well.
So I'll also leave everyone with a story. So when I took the job as I was the first global health lead for our health system, I asked our chief medical officer and the CEO kind of what success would look like. And they were like, we're not sure what it will be, but we'll know it when we see it. Just go out and figure it out. And inherent in that was this permission to fail a couple of times. And I think that's really important. The private sector is very good at that. We're very good at trying things, and if it works, great. If it doesn't work, we pivot and try something new. And the public sector has a much harder time doing that. And so the partnerships of that, very, very important, because when you have to answer to a congressional committee or to a multinational constituency, it's much harder to try and pilot new things. And again, I want to just double tap the aligning motives. So, and this is not my story, but I was told by the CEO of JSI last year that they've had tremendous success working with MasterCard, not MasterCard Foundation, MasterCard, at improving connectivity in sub-Saharan Africa. Because if they can improve connectivity, not only can they improve digital health, but people will start using mobile wallets and paying with a MasterCard. And so it's one of those perfect examples of it doesn't always have to be development dollars. You can align the profit motive and just be in the room to mention the other benefits that they can also share credit for. And so it is our responsibility as the experts and the subject matter experts to hold them accountable to what they say they're going to do. So it's not lip service and it's not greenwashing or whatever washing we're going to do. But I think it's really powerful and it has the ability to really accelerate what we're doing. Last point is I'm really proud of the fact that I'm the token man on this panel. We need more women-only or token men panels in Davos. The mantle has to die. So I'm very glad. And my experience is that women are going to fix the world for us. So thank you.
Woo.
All right, just for us to give a chance for the audience as well. But I mean, not sure about the women who fix the world, but I think this kind of like collectively thinking will actually fix the world. So just to kind of maybe close the loop on the partnership, right? I think we do have a very good representation here, all different stakeholders that needs to come together with the subject matter expertise and with the ability to do the right thing in their own field, to sit down and make those things successful, right? So industries can actually bring the expertise of developing technology. AI is a big thing. Carla, Sabine said a little bit about bias, so we need to make sure that we are encompassing data that comes from different parts of the world, right? We need to make sure that we're engaging with regulators to make sure that this is safe and performing as intended. Then we need to partner with the providers to make sure that this is kind of use it properly. But we need partnership and funds, right? It's how we get to the places where we cannot go with the normal type of business case or access, right, with our sales force. So how we think out of the box, how we look for different partners that can take a truck, right, with an ultrasound machine powered by AI, right, that can also not reduce CO footprint, but also give access to people that cannot get there. And how we actually find those buckets, right? Beyond, I would say, if we're really looking for equity, beyond the ability to offer that for free only, because that it becomes a matter of time. And we all have been through like discussions about Africa and how much nonprofits have been able to do in Africa, but then after a year or two, they leave, right? And then we do not develop. I think I love your example of the MasterCard, right? Develop the infrastructure for them to keep growing. And this is where I believe is the power of collaborating.
Well, I can keep asking you all questions all day, but I will let you all have a turn. So before I do that, though, I want to, where are you? There we are. We're going to start with Dr. Solomzi Makohliso, the deputy head of the Essential Tech Center at EPFL. He focuses on leveraging cutting-edge research for sustainable development in low and middle-income countries, and he is going to get us started with our question and answer session. Doctor, the floor is yours.
Hello. Yeah. Well, thanks for the invitation, and thanks for this stimulating discussion from the panel. I happen to be an engineer, and so I'm likely to add to this a perspective that comes from an engineering perspective, since we're talking about technology anyway. So let me start by going first to the initial part of this discussion, where we actually talked about the power of digital technologies as enablers to try and scale access to global care. But of course, we know that for digital technologies to work, we need data, and for us to be able to get data, we need hardware and physical devices that can actually generate that data that's necessary. But in the case of medical devices, it is well known that Many of them are in fact very poorly adapted for some of the contexts that we're referring to, especially these resource-constrained and underserved communities. So my question is, the first part of my question is that, aren't we forgetting the elephant in the room if we are overlooking really the issue of a lack of suitably adapted medical devices that are required to generate this data, to begin with? Because in my view, really, this is an important variable in what I would like to term, when trying to confront what I would like to term the digital value chain equation. I love equations. I told you I'm an engineer. And perhaps something that's somewhat related to that, and even to the speaker that talked about COVAXing a lot. We all remember, obviously, how the COVID pandemic actually exposed the fragile, global supplies, especially for medical, And then my question is, to what extent, we know that if we had, for example, some reasonable capacity to locally manufacture simple devices such as ventilators, many, many lives would have been saved. Now, the question is, as the second part and last part, to what extent would the promotion and acceleration of local manufacture of certain essential medical devices be part of the solution to, perhaps to my first question, while at the same time, contributing in strengthening local supply chains, and also helping, policymakers towards, their quest to actually achieve systemic change in this sector. Thank you.
Who wants to take that? Those.
It's open to.
I nominate the medical device company.
Voluntarily, right? So I think this is an amazing question, and we can definitely be debating this for a long period of time. But I'll start with the first one, right, about data. So we know that we are capturing a lot of data from medical devices all over the planet, and even for devices that are not necessarily medically regulated. And we do have a lot of data, but very little yet, I would say, kind of guideline or solutions coming from that data being organized and help us to define next steps. And I think there is a huge opportunity in your question to, again, touch base on collaboration with regulators and policymakers, and how we create something that goes beyond geographical barriers. Because that is really kind of like pushing back, or probably slowing a little bit the companies like Philips and other companies. I'm sure I'm representing other companies as well, as we think about developing technology through data or AI. Right, so we did have a very good evolution in some of the guidelines about what can be done and how do we validate AI, but it's still very early stage, right? The AI Act for EU has been recently launched. FDA is still working around this, and other countries have different regulations and laws. And so this is one of the biggest topic on the agenda around how we can make sure that the data coming from the device has clear rules of engagement about who owns the data, how can we manage that data, how we connect this to the cloud, right? So we don't want to get into politics, but just now we're having a lot of discussion about ownership of data and how much countries can determine how we move forward in that direction. So I think this is a huge challenge, and also an opportunity for us to push into the top priority on the agenda, how we streamline the ability to safely develop technology that is coming through the data. The second part of your question, if I understood that properly, right, it is about also open source. Yes, we've seen through the pandemic, and I was not with Philips at the time, but I know Philips approached it the same way. Most of the companies that own ventilators were kind of creating open source. But we know that this is not as simple because of the supply chain, because of the challenges of actually having systems that are safe and that can perform as intended. That's not something simple to be replicated. I believe that this is another big, interesting topic for us, because in the same way that I believe there is a need for us to localize as much as possible to make sure that in case of something happens like a pandemic, we see the benefit of having access locally. We also need to see through the lens of the industry, right? Localize and have 35 different sources of specific supplies is not something easy for you to ensure quality and performance. So there is a balance there. And this was a big part of the agenda with the World Health Organization last year. How much can we actually localize without losing on the quality, specifically on high complex medical devices, right? For the simple ones, definitely easy, but for CT scans, MR machines, ultrasound, kind of applying software as a medical device on top of it, it's not that simple for us to kind of spread out the manufacturing process. So I think that is another great example where we need to sit down and look for that common goal. What is the right balance of localization and where we can find alternative paths for a business case that in case of a problem, of a disruption on that supply chain, we still have a way to serve that region without going too thin and probably impacting the ability to have high quality products. So it's not an easy answer, but I think definitely touch base on 2 points that I feel are topic for future discussion.
Any other questions from the room? I saw your hand first there.
Hi, everyone. My name is Sneha. It's my first time attending Davos. I'm super excited. One of the questions I had is, I think in the healthcare system, we often see patients as a problem to be solved, and we listen to them. We might listen to them, but we don't allow them or give them space to be activated members of actually driving the reform and driving the change. And I think patients are actually the most important stakeholder in these conversations, and NGOs are not always representing the patient voice. And I'm so curious to know how you all think about in your individual companies or organizations, how you think about not just listening to patients, but working with them. In my organization, we're a patient advocacy group. We led 8 peer-reviewed publications. Long COVID was first created by patients who were, the first peer-reviewed publication was created by, on long COVID was led by a long COVID patient advocacy group. So how are you all thinking about that in your work, and how do you all see that as part of the future of really using the patient voice to be driving some of the future of healthcare reform?
Could I jump in? I think that's a great question. I think this requires this empathy mode and the knowledge and that we don't know all the answers, right? So when we started, I'll give you one example. We have a strong also program around women's health. And when we started taking care, we focused first on the disease, right? So cervical cancer screening. And when we started taking care of these women, we understood that many of them had gynecological problems because of domestic violence, right? So we started addressing that challenge as well. And there was a huge demand for mental health. So we started addressing that challenge as well. And when we started seeing that they had a problem with urinary incontinence, and this is a disease that we never even thought about because it has a huge taboo around that topic. So we started taking care of that. And I think this requires this humility that we don't always have, right? Especially, I'm sorry, I am allowed to say bad of doctors because I'm married to one, but especially doctors sometimes, right? They want to focus on the disease and give the diagnosis, and I think this creates an important point that who we are actually serving is the patient, but they can also serve us, right? How can we improve by listening? And I think that's a great question and something that we always have to bear in mind.
I think we have time for one more question, maybe. Okay, I think I saw your hand, white scarf. Yeah. Sorry.
Thank you all. Lots of nodding along this morning. Eric, you made a point about when it was just a quick part of your story, but you asked the Minister of Health, what problems are you having? And so I'm curious if you can talk about, anyone on the panel, how collaborations and partnerships can put community and local needs and solutions at the front of the partnerships rather than this top-down, we're going to bring in a solution for you. Thank you.
Yeah, I mean, that's kind of the innovation around the Center for Global Health was we are entirely stakeholder-led. And I can actually tell you, in a country like Guyana that has the second highest suicide rate in the world, we really thought that starting with the community and community-based screening was the right approach. But we talked to the health system and we talked to the Minister of Health and the psychiatrist there, and they're like, no, we want electroconvulsive therapy for severe schizophrenia, depression, and that's the modality that we need right now, immediately. And that was not where we were going to start. And it probably wasn't the second place we were going to start. But they were pretty insistent that that's where they wanted to start. So that's where we started. And we delivered the first ECT training after a year of partnership. And I'll tell you, our engagement on the community-based interventions now is way better because they do recognize that going upstream is an issue, but they spent a lot of their time in the tertiary hospital not treating severe depression and schizophrenia. And so by listening to our stakeholders and putting our stakeholders in the driver's seat, we gained their trust. And that's a very important part of the theme for last year in Davos was rebuilding trust, right? I mean, trust is an important part of a relationship and a partnership. And without that, you really can't be efficacious. Listening is also part of that, so whether it's listening to patients or listening to the local doctors. I joke that 90% of my job is just talking to the frontline doctors in a country and then echoing it to the Minister of Health because they'll listen to me because I'm from New York. But it really is kind of allyship, partnership. Those are all very important parts of building that trust to really get the work done.
Maybe on that, in our field, we call it, and it's something we really believe in, is accountability to the affected population, meaning that they are the primary source that should design the humanitarian and development solution that you're providing on the ground. So it connects with that. They're not patients, but beneficiaries. But we also don't use the word beneficiaries anymore because it's not a top-down global north to global south. So the whole landscape is changing. And some of the solutions are coming from the global south and also what we call south-south. Brazil could share ideas with India or with Nigeria. I mean, we need to also incentivize all kinds of upstream movements that break that cycle of global north to global south.
What we did, and this is sometimes you have to look at the mirror, right? And we looked at our board, and we had no one from the community. So we invited a community member to be a part of our advisory board. And I think these are the small steps that make a huge difference, because if you want to serve them, you actually have to hear their voices, but not once you have the idea of the project, then you're trying to listen to convince them that you're right, but actually have them on the table and being a part of the strategic decisions as well. And I think this is an interesting question, right? Ask our organizations, who's a part of your board? Who is a part of the decision-making process? Because that's where things get done. And also, I think this is a concern that we raised, and we looked at ourselves and said we're failing on that. So let's move and do things differently as well.
Well, I know we all have many more questions, but I have promised to give you now 6 minutes to chat amongst yourselves and continue asking our panelists questions. But just to wrap, I mean, we've talked about so many different things today. A couple things that stick out to me are when you think about partnerships, the importance of language, the importance of speaking the same language and bridging different languages. There's the importance of access. Are we thinking about it? Who's on our boards, as you just mentioned? Who are we thinking about? Are we listening to our patients and ensuring that we have all those right pieces in place? There's the issue of cardiovascular health is still a major problem, but there's bright spots. And how can we learn about this? I think we've talked about AI, we've talked about technology, we've talked about innovation, and we've talked about working together. So maybe I'll just leave you with what Carla said, which is we should COVAX this. And we should think about ways that we can come together better. We can COVAX cardiovascular health, global health challenges beyond just the immediate crisis of a pandemic and go toward non-communicable diseases with that approach. So I'll leave it there for now. I want to thank you all so much. Thank you also for those who listened on the live stream. And thank you to our audience for being giving us great questions to think through. So thank you all.
Thank you.